Hello friends, normally in distal femur fractures we use the lateral surface for plating both the condyles, and usually in this area the screws are inserted from the lateral side and they gain purchase on the medial side as well, and usually that is sufficient fixation for distal femur fractures. But often when there is extensive combination we have a doubt whether to supplement the fixation with a medial plate or not. So in this presentation I will be talking about all those points based on the published literature and some points based upon my experience that will help in deciding whether we should go for a medial plate or not. So when to do the medial plate? So the medial plate should always be used in such scenarios whenever the stability is compromised. I'll show you when this happens and when there is extensive comminution in the articular area and sometimes in the metaphyseal area also, that we will be seeing in the coming slides, and whenever there is compromised bone quality, that could be because of the osteoporosis. So whenever there's doubt about the stability, we have to go for a medial plate. So in periprosthetic fractures like this, the screw hold that we are going to gain from the lateral side will be compromised because of the processes. So we need additional stability that will be provided by the medial plate. So whenever there is a periprosthetic fracture, definitely you have to go for a medial plate also, otherwise there will be risk of early loosening of the implant and sometimes implant failure. And when there is extensive diaphyseal or metadiaphyseal combination like this, then the lateral plate alone will be absorbing whole of the stress because of the void in this region, and that can result in early implant failure. So in those scenarios also you have to supplement the fixation with the medial plate. And in some scenarios when the fracture pattern is different, that means you don't have simple lateral condyle and medial condyle, and you have additional fracture pattern in form of coronal shear injury like a Hoffa's fragment with a metaphyseal spike protruding proximally. So this is an injury in which the fracture displacement can occur in this plane, the posterior plane also. So you need to supplement your fixation with an additional plate that should buttress this apex of the fracture. And if you are not placing that, then there will be risk of failure because the screws that are going to gain hold in this area because of the lateral plate will not be able to cover this unstable zone. So we need additional plate in this area, which can be medial or posteromedial depending upon the area that needs to be covered. And in some scenarios when the fracture is very low, the lateral plate screws are going to get hold only in this much area of the distal fragment. So the stability it is going to provide will be compromised because you are having only 2 or 3 screws in this zone, because you can't push the plate downwards below the level of the intercondylar notch, and therefore the number of screws will be reduced. So to provide additional stability in such scenarios also, you should supplement your fixation with a medial plate, because that is going to give you additional screws that will gain hold in this small distal femur fragment. And in osteoporosis, that means the poor bone quality patients, you need to add a medial plate. Why? The screws that are going from lateral side to the medial side, that means from this side to this side, will not be able to sufficiently gain hold in the medial side bone because it is of low quality, and this fragment has tendency to go outwards. That means there will be displacement of the medial condyle, and sometimes there will be risk of varus collapse as well. So you see the trabeculae here are sparsely visible, while on this side the young patient, they are quite visible. That means they are thick. So in young patients, whenever there is intact medial condyle, then definitely you can use a lateral plate and gain hold on the medial side with the lateral plate screws alone, because the purchase of those screws in this segment will be a stable one, unlike an osteoporotic patient. But in scenarios whenever there is osteoporosis, even if the fracture is simple, that means there is no major metaphyseal combination, then also you should supplement the osteoporotic cases with a medial plate. While in young patients, you can go for a lateral plate alone if the bone quality is good. And in some cases, suppose in old patients, you don't want to add soft tissue damage, then you can supplement your fixation with an intramedullary nail also. You can either use a longer nail and smaller plate, or you can use a smaller nail and a longer plate, because often when you use the longer plate, this area is already containing the nail, and the screws have to go in a manner so that the nail part does not not block those screws. Those screws are often compromised. You have to go for a screw which is not perfectly going inside the canal. It is going eccentrically in the canal just to avoid hitting the nail. So in those scenarios, you can use a shorter nail inside the canal and use a longer plate which will gain hold in the proximal diaphysis, and that will be an optimal one, and you will be getting benefits of both the nail as well as the plate. So whenever the fracture is a simple one, simple articular, that means C1 with no metaphyseal comminution and no articular comminution, then you can use this kind of construct in osteoporotic patients. And whenever the fracture is like this, that means articular simple and metaphyseal comminuted, then also you can use nail and plate construct without using the medial plate. But whenever there is articular comminution, that means you find that there are multiple fracture planes in the articular zone, then you have to use the medial plate, because the nail will not be able to contain the medial segment with a buttressing effect. The buttressing effect has to come from outside, not from the inside. And if the buttress is inadequate, then again there will be chances of loss of reduction, and sometimes the medial condyle migrates more medially and later on displaces. So putting the nail screws are like putting fingers over the medial condyle. If you feel that the fragment is large enough to get stability with these many screws, then definitely you can go for the nail. But whenever there is combination in this zone, that means there is Hoffa's fragment with osteoporotic bone, then definitely you have to use some kind of a buttress plate on the medial side. Otherwise, there will be chances of loss of reduction. So this is the kind of impact we want whenever the fracture is an unstable one with articular combination and the screws of the nail or the lateral plate alone are not able to contain this medial side fragment, and you want buttressing effect over the medial condyle to keep it contained with the lateral condyle. So in those scenarios, you should definitely go for a medial plate, not the nail, not the plate alone. Nail plate combination can be used in simple articular fracture patterns and in osteoporotic patients also, but whenever there are chances that the articular segment on the medial side is comminuted, having multiplanar fracture pattern like Hoffa's fragment with a metaphyseal spike, then definitely you have to go for a medial plate. In those patients who have comorbidities like renal issues, diabetic and other endocrinal abnormalities, in those the healing potential is reduced. That means the bone quality may be compromised, may not be, but the healing potential is definitely compromised. So what we need to do, we have to wait for a longer period till union. So ultimately, when the fracture has not united yet, the stress of the knee movements and some weight bearing goes directly over the implant, and with frequent weight bearing, knee movements and other activities, the implant may get fatigued and it may result in implant failure. So we want the implant to bear more stress till the fracture gets united. So in those scenarios also, you have to go for a medial plate just to add additional stability till the fracture unites. So these are some scenarios in which the healing potential is definitely going to get compromised. In smokers, there are issues of delayed healing. In open fractures also, there are chances of delayed healing, and in those scenarios, when you have exposed whole of the bone just to gain good articular reduction, then again the vascularity of this area has been compromised and healing is going to get delayed. So it's better to supplement the fixation with a medial plate that needs to bridge from this area till this area, and you need not to put any screw in this zone, and the medial plate will add additional stability to your construct. It will not make your construct rigid because this metaphyseal combination zone will be void of any screw. So it's all about the timing. If you feel that your patient has tendency to go into delayed union, then better to supplement your fixation with a medial plate as well. And there are some concerns about the timing of the medial plate, whether to do it in the same sitting or the other sitting. So in the same sitting, you have to do the medial plate when the patient is a stable one and you have all the indications of the medial plate that we have discussed earlier. There are no medial side wound issues and the healing of the soft tissue is not compromised, because often for medial exposure you have to retract the skin towards the medial side, and if there is slightest doubt about the healing potential of the patient, then better to time your fixation on the medial side in a staged manner. That means you go for a lateral plate at one sitting, and after 6 weeks when there is some consolidation at the fracture site, then you go for a medial plate with or without bone grafting depending upon the fracture pattern. That means if it is extensively comminuted, then you can go for additional bone graft also. You can add fibular strut also. If it's not there, then you can just add the medial plate later on. And if the surgery is not getting prolonged, then also it's better to get a medial plate fixed in the same setting. And the medial plate fixation can be done at a later stage also. Suppose in a patient who is already having multiple injuries, and adding a medial plate, you need additional exposure and it is prolonging your surgery, then definitely you can delay it to a later stage. And if there are some wound issues on the medial side, some healing issues, then also you can delay your medial plate fixation. And whenever you have doubt about the plan, that means suppose your medial condyle is having good bone stock and you have good bone purchase on the medial side from the lateral plate alone, but you are not sure about the metaphyseal comminution, whether it is unstable or not, then definitely you can wait and follow the patient closely. If it ends up into delayed union or there are some signs of change in reduction, then you can use the medial plate at a later stage. But if the fracture is uniting well and you are seeing good bridging bone formation, then definitely you can avoid the medial plate in doubtful patients. So whenever the plan is doubtful, you have to keep the patient non-weight bearing and closely follow the patient at monthly intervals. Now conventionally, when we address the articular injuries of the distal femur, we go either with the lateral parapatellar approach or we use the swashbuckler approach that helps in additional medial exposure. So that can be used according to the surgeon's choice. The medial exposure mainly depends upon the proximal retraction. So if you are able to retract the muscle medially on the proximal part, then definitely you have sufficient space for placement of the plate on the medial side. And in those scenarios when there is extensive comminution on the lateral side as well as medial side, the surgeons often prefer dual approaches. That means there is an approach for the lateral side and there is an approach for the medial side. In those scenarios, you just mark the area which has the most unstable region of the fracture. Suppose there is a fracture spike here on the medial side, then definitely you have to place your implant on that area, because the area which is having the most unstable zone has to be buttressed by the medial plate. And if the spike is here, then definitely you have to go slightly posterior. And what you need to do, you have to identify the junction of the vastus medialis muscle with the intermuscular septum, that I will be showing in a separate video. And after tracking the muscle anteriorly, you will be able to expose the medial surface of the bone. Then you have to remain on the bone throughout. Use a blunt bone elevator behind the condyle, and that will help in exposure of the fracture. And avoid any sharp instruments and remain on the bone throughout your procedure, then you'll be safe. So this kind of fixation we are aiming for. You need not to put the plate till here, because here the medial condyle is quite prominent. It is very difficult to plate this area. If you place the plate till this area, then definitely you will face some implant related complications like implant prominence and impingement. The plate should be able to effectively buttress this flare of the medial condyle. The flare of the medial condyle is like this, and you can plate this area. So in this case, you see we have used the swashbuckler approach to expose the medial side and then pass the plate over the medial fracture. But often you have difficulty in placement of the screws, because screws have to go from the medial side towards the lateral side and retraction is often insufficient. In those scenarios, what you can do, you can simply put small stab incisions on the medial side and through those pass your locking sleeves, just like we do in MIPO plating. So you need not to retract this whole flap on the medial side just for placement of the screws. If you are facing difficulty, just put small stab incisions here and place the screws. They heal well and your incision healing does not get compromised. There are some safety concerns regarding the placement of the plate on the medial side, because often the residents are scared about the neurovascular structures on the medial side. So you need not to worry about that. Why? Because for placement of the medial plate, you have to use an anterolateral incision. So suppose this is diaphyseal area and you want to place medial plate in a minimally invasive manner. That means you want to pass the plate from the medial side of the condyle and you want to extend it proximally till the mid part of the diaphysis. So what you need to do, you need to give an incision on the anterolateral aspect, and through the muscle plane after hemostasis you have to directly reach to the bone. You don't have any important neurovascular structure in this area. That means you go through the vastus lateralis muscle and vastus intermedius muscle to expose the femoral diaphysis. Then use blunt instrument to retract the muscle on the medial side and lateral side. By that you will be able to expose the anteromedial surface of the femur. And you need not to place your plate over the posteromedial side. You have to keep it anteromedial. Why? Because you see the medial medial condyle of the femur is rotated. You have to plate on this zone, and this zone is actually facing anteromedially. So ultimately your plate is going to be over the anteromedial surface proximally as well. Place the screws in this zone under direct vision. Do not do any dissection in this area, because if you do that, you are actually hampering the fracture biology. And fracture biology is critical in comminuted fracture, and those fragments, the comminuted fragments, should not be touched at all. You just place an incision on the medial side, then pass the plate proximally to bring it at your incision site, and then you can position it over the anteromedial surface of the femoral diaphysis. Then after centering the plate distally, just put cortical or locking screws proximally depending upon the bone quality. Now some examples. Here you see the fracture is an osteoporotic one, and the fracture is definitely in multiple planes as well. That means there are some Hoffa's component, and additionally we see this spike which is extending over the metaphysis. So ultimately it is an unstable fracture pattern, and definitely in a poor bone quality patient. So here there are definite indications of medial plating. But you see, the surgeon had reduced the fracture well, he had fixed the Hoffa's fragment well, but ultimately it get collapsed in varus. There is some displacement and proximal migration of the medial condyle. That means the lateral plate alone was not sufficient to contain the medial condyle. We definitely needed a buttress plate on the medial side in this scenario. Now here in this example, there is an unstable fracture pattern. You see there is a metaphyseal spike here, and it is displaced. So we need an additional implant to buttress this metaphyseal spike. You see the surgeon again has reduced everything well. He has placed multiple headless cancer screws to address the Hoffa's component, but this spike has not been effectively buttressed. Therefore, it collapsed, and a medial plate over the posteromedial surface could have been helpful in preventing this displacement. Now here you see the fracture again appears to be well reduced, but the implant here is a small implant, a recon plate, a 3.5 mm recon plate. In lateral view it is also perfectly reduced, but again the implant you see here, it is not covering the medial condyle well. If you see the preoperative radiograph, again you see there is a spike in this zone. That means again an unstable fracture pattern, and there is some Hoffa's component on the medial side. You see the surgeon has placed headless screws to address that Hoffa's component, and it resulted in collapse because the buttressing implant is ineffective to contain this whole metaphyseal spike. So whenever you are using the medial plates, you have to also ensure that the medial plate is effectively buttressing the condyle, especially that area which is an unstable one. So if there is Hoffa fracture with a metaphyseal spike here, you have to place your implant close to this zone. Either you can place a plate directly over the apex of the fracture, or if you are not able to do, you have to at least place the plate over the posteromedial side so that this unstable fragment is perfectly stabilized. So putting this implant is like this. You are buttressing the lateral surface well, but on medial side you are buttressing with support of just one finger. Do you feel it will be sufficient? Not at all. So you have to again place an implant which will be effectively containing whole of the medial condyle. So the medial plate looks like this. You need not to keep this plate down till this zone. You have to ensure that these 4 screws are going well through the medial condyle. If they are going close to the fracture site, then definitely you have to place your plate slightly lower, but not close to the joint, because otherwise you will face hardware related complications. So here you see in this x-ray, this is the usual manner in which the medial plate has to be placed, and you have to buttress that particular area which is the most unstable, that means which have tendency to displace in future. And when you are not having any options, and because of the limited resources you don't have proper medial plate, then again you have to use this plate over that zone which is the most unstable. And usually whenever there is metaphyseal spike on the posteromedial side, you have to place this plate over that zone, not over the anterior side like we have seen in this case. This plate was quite anterior. And also you have to ensure additional stability by placement of fibular struts that are perfectly impacted inside the medial condyle and the proximal diaphysis. So these struts are providing support like an additional plate. Another example, here you see the medial condyle appears to be intact. Here also it seems to be intact, but there is extensive medial side comminution and some comminution on the lateral side also. So the comminution on the lateral side was addressed with the lateral plate, and medial side no fixation was done because the patient was a multiply injured patient. And again, since the patient was a young one and we were able to gain hold of all the lateral screws on the medial condyle as well. And since the bone quality is good, we can definitely follow this patient to see whether there are signs of loss of reduction or if it is ending in delayed union or not. If something like this happens, then definitely we can use medial plate at a later stage. But if it heals well, then definitely we need not to do anything at all. So ultimately you see here, because the fracture biology was preserved, this fracture united well without the need for an additional medial plate. You see there is bridging bone formation here and here as well. So ultimately you are preventing additional procedure in these patients just by ensuring good follow-up and also respecting the indications that we have discussed earlier. That means if you have good quality of bone on the medial side and you are able to get good purchase on the medial side, then definitely you can plan your medial plate fixation at a later stage also. Now in this scenario, you see there is extensive metaphyseal comminution both on the medial side as well as lateral side. So this is a case I was talking about in which there is no support of the bone on medial or lateral side. If you place an implant on the lateral side, whole of the stress will be directly consumed by the lateral implant, and ultimately that will get fatigued with time and may result in failure. So here a medial plate was placed. Again you see it needs not to be perfectly down towards to the terminal part of the medial condyle. It has to effectively buttress the flare of the medial condyle, and in a scenario when you don't have a longer plate to effectively span the comminution and pass screws proximally, then you can use the opposite side lateral plate that can be used as a medial plate on the contralateral side. Now we are using the lateral plate of the right side on the left side. So here we have effectively bridged the comminution. Again the construct is not a rigid one, it is just more stable. Why? Because no screw is passing through the zone of comminution. It will add stability without making the construct rigid. So ultimately this is the 3-month follow-up. You see there is some extra bone formation or consolidation happening over this area, and this fracture is definitely going to unite well without any complications because you have respected the biology. You see small incision has been placed on the medial side and lateral side, and we have not opened this area, and proximal screws on the medial side have been placed in an open manner, but they are quite far from the fracture side. So we have preserved the biology, and that is going to make this construct heal. Now in this scenario again you see there is some comminution on the metaphyseal side, but the articular part is still simple and the bone quality is good. You see thick trabeculae. So it was fixed with single lateral plate and most of the screws were covering the medial condyle, and it healed well without the need for an additional procedure. Now in this scenario you see there is extensive comminution on the medial side, and lateral side also there is some comminution, and there was some bone loss also. Now the fixation was done on the lateral side alone. There was additional open injury which you see because of the irregularity of this skin incision, and because of that open wound the surgeon preferred to wait for some more time to decide whether to go for additional medial plate or not, because by doing them he will have to expose this much area also. Since this is an open injury, he may actually add to more damage, and he thought it's better to wait to see whether the fracture is landing in non-union, delayed union or not. Ultimately what happened, because he respected the biology, there is good consolidation of the bone on the medial side. This fracture spike is having good bony consolidation, and there is bridging bone formation here and here as well. Now you see the medial condyle was a single fragment and there was good quality bone. You see there are thick trabeculae visible here. Patient was a young without any comorbidity, so probably that helped in maintaining the strength of the fixation construct, and therefore it united without the need of medial plate. But again you have to follow these patients. So this is a case in which you have a doubt whether to supplement your fixation with a medial plate or not. So in those scenarios you can definitely stage your fixation. So I hope this presentation will be helpful for you in your decision making regarding the medial plates. So whenever you have a doubt about the bone quality and extensive comminution on the medial side, and in selected patients in which you are anticipating delayed healing, then you can supplement your fixation with a medial plate, and the plate has to cover the most unstable zone of the medial condyle, not anywhere, only that area which has tendency to displace. So that will help in good outcomes. If you have any queries, you can just put those in comments. Thank you.